So, without further ado, welcome everyone to today's COVID-19 briefing with Ari Johnson. He is the co-founder and CEO of Muso, an assistant professor at the University of California, San Francisco, in the Global Health Sciences Department. Ari, welcome to today's briefing.
Joe, thanks for having me. I'm great to be here.
So, Ari, you and I talked about this at the beginning. It actually turns out that the majority of health experts that we've had join us for these briefings so far have all been based and working in predominantly the UK, some more broadly abroad, including sub-Saharan Africa, but 100% have been based in the UK. I think although the whole focus of today is going to focus much more on kind of West Africa, I think it would be remiss not to ask you what life is currently like in California. I know you're based in the Bay Area. And today I know that New York reported a drop in their new infections and death rates. Does this spell hope for the US, and what are you seeing and feeling on the ground there?
Thanks, Joe, and thanks for having me. So from here in San Francisco, and I can say everywhere, this is a dire moment for all of us, a moment of shared vulnerability and great emergency. And despair is a luxury. It's a luxury that our patients can't afford. It's a luxury that we can't afford. So hope is a necessity. And in the United States, we're far from out of the woods. I think especially as COVID continues to spread into smaller towns and rural areas that have less capacity, we could continue to see a further rise in the days and weeks to come. And we still don't know the full extent of that. And at the same time, we are learning more and more as the outbreak continues what works and what we can do to make change. And there are points of light even within the chaos that is the United States' that has been the United States' response to date. And the points of hope and light for me in the US are, number one, seeing what can happen when health systems move proactively and early and quickly. And so California, the governor of California, was one of the first governors in the nation to declare an emergency and to order shelter in place. That happened much earlier in California than in other states. And we're seeing the positive impact of that, that the growth of cases in California and San Francisco has been slower. And we now have a situation where San Francisco, where we're all mobilizing rapidly, where there's a significant number of cases, more than 500 cases, still has now fewer cases than a small town like Mecklenburg, North Carolina. And so those things tell us that early action and proactive and decisive efforts on all of our fronts can make an enormous difference. The other point of light for me is being on the front lines, providing care for folks being tested and treated for COVID in the hospital. As a physician, is the resilience of patients and the dedication of providers. And when I say providers, I mean all providers. That means the custodians that are taking care of the biohazard bags and the other waste disposal. That means the medical assistants that are taking the vital signs, the nurses, the physicians, the administrators. It takes a whole team of teams to make this response happen. It takes all of us.
Thank you, Ari. And just moving on, I know we're going to dive a little bit more and you're going to explain more the model of Muso Health and what you guys focus on. But to start off with, as a basic kind of generalization, Muso generally works in Mali and obviously in some other countries in West Africa. But before we dive into the exact work of Muso, I would love to kind of just get your outlook for, in general, West Africa. What does this look like in terms of the pandemic? And how does that expand across the sort of global south in terms of what we can expect to see and what we should be prepared for?
Yes, thank you so much for asking that question. I don't think that we collectively as a global community have spoken very much about how COVID is going to impact communities across the global south, how we're not talking enough about how it's impacting and going to impact the most vulnerable communities. And that's incredibly important. So a fantastic team, the COVID team at the London School, recently put out modeling to project what is going to happen in the coming weeks across sub-Saharan Africa. And what we see from that is that by the end of May, most countries in sub-Saharan Africa will have 10,000 cases or more. That means that across sub-Saharan Africa, we should expect to see, we could see 400,000 cases or more by the end of May. That would mean that sub-Saharan Africa by the end of May could have more cases than the United States, the entire United States has today. And the gravity of that is vital for us to absorb because we should not expect the risk of mortality from COVID-19 to be similar across sub-Saharan Africa as it has been in the United States. In the context of health systems where many people, huge portions of the population have little or no access to healthcare at baseline, and where health systems capacity is already struggling. So take, for example, something that we take for granted across the global north, which is oxygen. So we know that about 4 out of 5 patients who get infected with COVID have mild symptoms and can get care at home and do all right. And then somewhere around 20% of patients need hospitalization. And we talk a lot about ventilators and the need for ventilators. That's incredibly important, that capacity in every country responding to COVID. But we don't talk enough about oxygen. Most people who are hospitalized who could die from COVID, what they need most is actually oxygen. It's a life-saving therapy, one we take for granted in global north, and across the global south, it can be much harder to come by. For example, across all of Mali where we work, a country of 19 million people, there's not a single district hospital to our knowledge that has the capacity to provide oxygen to its hospitalized patients. So thinking about some 15, 20% of patients with COVID within that 400,000 getting sick enough to require oxygen, we could see the risk of much, much higher mortality than we've seen so far. So the situation is urgent, it's dire.
So let's deep dive into that a little bit more, Ari, and potentially you can dive into sort of the specificities of Mali as a case study. As you were saying, the baseline healthcare for many of these countries is not there. Access and timely access to healthcare is not there. How would you sort of diagnose the problems and challenges that we see in place right now? And what could be some solutions to look at overcoming those?
I think a great case study for us to learn from is the situation of Ebola from 2014. That is a really important crisis for us to learn from. I was in Mali during the West African Ebola crisis. During that outbreak, you probably didn't hear much about the outbreak in Mali, and that's because in a shocking turn of events for all of us, that outbreak got shut down incredibly quickly. And I think we have a lot to learn from that. Here's what happened. So in 2014, when the first 2 cases were confirmed, one was a 2-year-old girl who had just returned to Mali from Guinea with her grandmother, and another was a beloved imam, a religious leader. And between the 2 of them, it took them so long to get to care that they had already come into contact with 432 people by the time they got diagnosis and isolation between the 2 of them. And most of those contacts and exposures were across Mali's capital city of Bamako, a city of 3 million people. And so when we saw this, we saw the imminent risk of Ebola spiraling out of control across Mali. And we thought that that was actually the most probable scenario. And so the Malian government sprung into action quite quickly, along with the CDC and an array of partners, including the NGO that I serve with and lead called Muso. And so what we did together in that effort was focus on speed. During the West African Ebola outbreak, the average time in the first 9 months of that outbreak between when someone first got sick and when they first got care was 120 hours. Imagine being sick with Ebola and it taking you 120 hours to get care. That was not an outlier. That was the average situation during the outbreak. And you can imagine that length of time means many, many more people exposed with every new case, and a much higher risk of dying because you get care so late. And so in this situation, the prescription for stopping Ebola, and we think at Muso, the prescription for stopping outbreaks and improving health outcomes is speed. And so what we did with the Malian government in that situation was to support and train a national team of frontline community-based providers who went door to door to every single one of those 432 people who were at risk of contracting Ebola and visited them twice a day. And with that, we were able to bring down that average delay from 120 hours to less than a day, essentially accelerating detection of new cases by an order of magnitude. And when that happened, when we found every new case early and got every new patient the care they need, the isolation and support that they needed, the diagnosis they needed early, something extraordinary happened. New transmission ground to a halt. After that system was in place, every single patient that was diagnosed early survived. People stopped dying from Ebola, and the outbreak was over within a matter of weeks. And while COVID-19 has some very important differences in how it's transmitted, and it poses some new challenges to us, the fundamentals are similar in the sense that the extent of the outbreak and its toll in human lives and how it impacts every segment of our lives will be determined by how quickly and comprehensively and proactively we mobilize. And so what we learned from this is that we actually have the tools to stop COVID-19 through early proactive mobilization together with the government, and that's what we're doing now.
So that's a spell of positivity, Ari. Can you explain a little bit more about what that actually entails in relation to kind of COVID-19? So how are you quickly training up the community healthcare workers? How are you working with the government to make sure this strategy is put in place? And how do you move quickly enough to make sure that it doesn't become a huge problem for the country, and you do similar to what you did for Ebola and kind of nip this in the bud early?
Great question. So first, we need to be very focused about what our goals are. Number one goal is care, is to continue care, because care can easily become interrupted as health systems become overwhelmed with COVID and people become fearful of going to health centers. So continuity of care is critical. Number two, in order for that to happen, we must protect every health worker on the front lines who are bravely leading the charge. That's critical. Number three is we have to mobilize proactively to stop viral transmission. So continue care and surge capacity there, protect providers, and stop transmission of the virus, stop the virus. Those are the core goals. And how do we get there? The work that Muso is doing together with the government of Mali to forward those goals is on a number of fronts. Number one, to continue care, we're working with the government of Mali to toward equipping and protecting all the frontline healthcare providers across the country. So making sure they have the right protective equipment, and also they have the right protocols and training and curriculum that they need to use that protective equipment and provide the diagnostic and care services they need to provide every day, both for COVID and for all the other life-saving things that they do, like treating malaria and pneumonia and providing vaccination. So that's piece number one, ensuring that frontline providers have the protection and training that they need to continue care and do their life-saving work. Then, very, very importantly, we are working with the government of Mali, and we've developed curriculum and already trained and deployed the first team across the Bamako region, a region of 3 million people where nearly all cases to date are in Mali. And we have the teams we've deployed. One is of contact tracers, folks who are interviewing every single person who's been infected in detail and identifying everyone who could have been exposed, all the potential contacts. And then there are separate teams based in every district that we've trained, equipped, and deployed to do contact monitoring, just what we did during Ebola, following up with those folks every day, twice a day if possible, so that when someone develops symptoms, we can act quickly. We can mobilize to get them the supported care, the supported isolation that they need. And by doing that, we can try to get in front of this. The faster that we can identify new cases, getting them into supported isolation and care, the more likely folks are to survive, and the more likely we are to stop transmission. So those are the core pieces that Muso is working on in support of the Malian government.
And you struck on this just a minute ago and as you were answering the question, but it also linked to a question from one of our members. In terms of the kind of frontline community health workers, obviously they're deployed right out in the communities, interviewing everybody, obviously coming into very close contact with people who may or may not have contracted the virus. How do we help provide sort of PPE for all of those health workers? Obviously, we have problems in the UK, there's problems in the US in terms of making sure that there's enough protective gear for our healthcare workers, and I can only imagine the problems are exacerbated in countries like Mali. So how do we make sure that there's enough equipment for them, and what are the kind of challenges and how are you overcoming that for your workers?
Absolutely. So first is we must make the commitment together to all of our health workers everywhere on the front line that we're going to get them the protective equipment that they need. Starting from that point, it's very tempting for us to throw up our hands and say, if it's hard for me to get the masks that I need as a physician in San Francisco, then what's the use? Let's not even try for a community health worker in sub-Saharan Africa. And I think it's critical for us not to give into that temptation toward despair, because in a way, COVID is testing the moral fabric of our society right now, of our global society, because it's a moment at which we're all vulnerable. And in a moment when we're all vulnerable, the question then becomes, how do we care for the most vulnerable? That's how I think we need to be judging our own actions. What commitments are we ready to make for the poor? I think moments of crisis like this help us learn about ourselves and help us call upon our own moral compasses and really discern what is most important. So with that, we are committed to mobilizing with many partners as part of a broad coalition to get frontline health workers, including community health workers, the protective equipment they need to do their full job, provide full continuity of care. And for that, the first part is making sure that we get the projections and the modeling right. And so that involves working with government and all the government partners, including global health and financing institutions, to include all levels of providers, including community-based providers who are often forgotten, in the national projections of needs. And then there's the work of supporting supply chain and procurement to fill those needs sufficiently. In addition, I think one very important thing is training and equipping frontline providers with the right training. That means it's not enough to have the equipment, but also to have the knowledge and the training, the background to know how to wear it and remove it safely, because it's quite possible to contaminate yourself and to actually increase your risk of infection if you don't take on and off the equipment correctly, if you don't don and undon your mask in a particular way. And as we do that training, we also understand that there are going to be moments where there are going to be stockouts. And we need to prepare providers for those moments. And so we've developed also no-touch protocols. So if a provider can't get to all the equipment that they need, they know how to stay 6 feet away from patients with symptoms and provide a evidence-based protocol of care from 6 feet away in a way that protects them and protects the patient.
And Ari, you flag up the obvious question, therefore, which is how can we all help? I mean, we're all sitting here listening to you from the UK. In what ways can we help countries like Mali and other countries in West Africa and beyond in the global South in terms of preparedness for this pandemic?
We have immense power over what happens next. There is a lot that we can all do. With the exponential math of COVID-19, we know that a single case can become 50,000 relatively quickly. We also know that a single case can remain a single case if we do the right thing. And think about that level of impact that we can have when we act early and decisively. The amount of resources that Muso mobilized to support that national team of frontline workers who tracked down and stopped transmission of Ebola back in 2014, we ended up spending less than $50,000 on that. In the scheme of things, a relatively small amount of money, orders of magnitude less than the total committed, but because we're a small, nimble organization, we were able to mobilize that quickly. And because speed matters, because acting early matters, that the contributions of individuals matter a lot right now, because as individuals, we have the capacity to move a lot more quickly than global financial institutions sometimes. That means we can be nimble. That means that we can contribute to grassroots organizations like Muso and other organizations like that. So Muso is part of the Community Health Impact Coalition. And that's a coalition of organizations working across 32 countries, working closely with government to support these kinds of responses at the grassroots level. So contributing to those organizations that are working in close partnership with government, that are trying to accelerate the response, and doing it right now, doing it as early as possible, can have a catalytic impact, can be a turning point. Because it's true that COVID can and probabilities are will explode across the continent, but that's not a foregone conclusion. What happens next will depend on our own actions. And so we have immense power to make change to save lives.
Ari, I'm going to ask you and put you on the spot so you can send this to me afterwards, but can you send me the link to some of the organizations you were mentioning, plus the coalition, because then what we can do is circulate with our members that, so if they are willing and interested in supporting, they can find out more information and see how they might be able to help support.
Thanks so much. So the address for Muso is musohealth.org, M-U-S-O health.org. And for the Community Health Impact Coalition, it's chwimpact.org. And I can follow up in writing as well on that front.
Wonderful, thank you. I mean, we're running out of time and I still have so many questions for you. Where to start? Okay, let's go with, you know, the work that organizations like Muso do in terms of working with government and building out this sort of system of community healthcare workers always fascinates me, because it seems to be a process that really has redesigned really sort of healthcare delivery systems for the better, and has actually meant that a lot of people get care, they get a friendly face that they also know, they're really kept to make sure they maintain their medication. Why is something like this not being translated to, say, you know, the UK or US? Is that something that's simply not possible? Is it that it's just too disruptive? Why are our healthcare systems so different?
What a great question. As a physician myself, I was trained basically to sit and to wait. And I was, as trained, I was lucky enough to get training at some great health education institutions. I went to medical school at Harvard. I trained at UCSF for residency in internal medicine. And I learned great clinical skills for diagnosis and treatment. But I also essentially learned that the moral mandate of a health system begins when someone walks through the door and says, I need care. So I basically was trained to sit and wait for patients to come to me. And what we've learned at Muso through our research and work over the course of the past 15 years is that the most vulnerable patients, so many patients, never make it to the door. And so we're ceding a huge portion of the playing field by constraining our healthcare systems to the walls of facilities. Facilities-based care and capacitating facilities is incredibly important, but it's not enough. And so I think we have an opportunity collectively as a global community to reimagine healthcare, starting with reimagining the moral mandate, saying that our responsibility as healthcare providers and as the responsibility of health systems overall begins not the moment someone walks through the door of a clinic or a hospital. It begins the moment someone needs care wherever they are. And then the responsibility becomes for us to meet them, us to go out and meet the patient where they are as soon as they need our care. That's when the clock starts. And that's where our moral mandate starts. I think we have an immense opportunity to do that now. And there are new tools and technologies that will make that easier and easier for us to meet patients where they are. So I think that's where care can go over the next decade, and I think it's where it must go.
And lastly, because I knew you wouldn't mention this and I would have to prompt you to do it, but you mentioned just before we jumped on live with everybody that, you know, obviously when Ebola came out in West Africa, you were actually on the ground in Mali working. Obviously right now you actually were in the US and then couldn't fly over to Mali. And I know you're Skyping in daily and still supporting your wards and all of your community healthcare workers. Tell me a little bit more about what that actually looks like, but also therefore the possibility of remote working and remote doctors in supporting healthcare in different continents.
Absolutely. So I live in two places. I have a home in Mali in West Africa, and I also have a home in the Bay Area, where I'm on faculty here, and I've been seeing patients as part of the COVID response here in San Francisco. You know, it's hard to be far away from so many of our teammates on the front lines in West Africa, but I'm essentially there remotely every day. The core of my work is actually, the core of my work in Mali is actually supporting and bearing witness to amazing, heroic Malian healthcare providers. And I think that's something that we can all do. There's incredible talent, incredible human resources, great community health workers, nurses, midwives, providers who we have the opportunity to support from wherever we are. And that's what my work is looking like every day. I get up in the morning and I figure out together with the rest of our team, what can we do to support these incredible health workers who are serving their own communities on the front line.
Great, thank you, Ari. I think that's a brilliant way to kind of close out today's conversation. Thank you so much to everyone for joining us. Ari, thank you very much for joining us very early in the morning for you as well. It's been great to discover much more about Muso Health, and I look forward to sharing that with the community and beyond. Please do send us any ideas that you have in terms of how we can support, and we'll share that with the community. But in the meantime, thank you so much for joining us, and we look forward to seeing you again soon. Thank you very much, Conduit members, for joining us, and we wish you a very happy evening. Goodbye.
Thanks, everyone. Thanks for having me.